This is the second of two videos about intraocular lens implants. Intraocular lenses are used to replace the natural lens after it is removed in cataract or lens replacement surgery. In the first video, we explored what inspired their design and highlights of their development. These are the topics we covered. In this video, we cover design features and visual performance of current lens implants and how that affects which lens someone who is having surgery might choose. This is our plan for this video. You can skip around as you wish. Let's start by recognizing that the intraocular lens implant is a marvel of modern medical technology. Up to the middle of the 20th century, cataract surgery was less than terrific. The procedure to remove the lens was not very refined, and rehabilitation of vision was very basic. So much so that the decision for surgery occurred when vision was reduced to the point where there was nothing left to lose. The advent of the operating microscope and microsurgical technique, beginning in the 1960s, dramatically improved the procedure for removing the cataract. But a significant problem remained. Once the natural lens is removed, how to replace the lost focusing power? Technically, we describe an eye without a lens as aphakic, and we describe an eye with an artificial lens as pseudophakic. Before lens implants, vision was restored with high-power glasses with thick, heavy lenses that caused significant distortion in vision. Contact lenses could supply the high power with minimal distortion, but required the ability to manage them. Not great for the age group that was having cataract surgery. The real answer was to create an artificial lens. In video 1, we looked at the first lens design, which was implanted in 1949. Since then, the aim has been to develop an artificial lens that functions as well as your natural lens. No small task. In video 1, we reviewed the steps of cataract removal. After entering the eye, the cloudy lens is broken up and removed. Then a replacement artificial lens is inserted. With a new clear lens, vision is improved with the range of visual function depending on the design of the implant. Which leads us in this video to explore the properties of current lens implants. We're not going to cover all the implant models or all the technical details. Rather, we will cover the general types with the advantages and compromises that would be useful to someone choosing a lens. In the end, the decision to have surgery and the choice of lens requires a thoughtful discussion with your surgeon, depending on your individual needs and preferences. With that, we are ready to begin. The first question to ask is, what are the visual needs in our daily lives? The monofocal lenses are a big improvement compared to no lens, but our activities of daily living don't all occur at a single distance. Yes, we need clear vision for distance and driving, but a lot of our activities occur at arm's length, like a computer screen, sheet music, and the instrument panel of your car. And there is reading and close-up work. Since the 1990s, a lot of effort has gone into developing implants to better address the visual needs of daily life at all three distances. Part 3. We are going to do an overview of the features of the different kinds of lens implants. There are three categories of implants: single power, multifocal, and flexible. There are also toric lenses for astigmatism correction, which we will discuss later. We start with a summary of the general properties of each lens type, then later discuss details of how well they function and what are the compromises. First and simplest, a single power implant with one focal distance. It has three advantages. It gives a high level of image quality. It has good performance in low light because the entire lens is gathering light. Also, it is the least expensive and is usually covered by insurance. Years ago in cataract surgery, we only had single power lenses. Usually, we put distance lenses in both eyes, meaning glasses were needed to see up close. One notable exception was people who were nearsighted before cataract surgery. They often preferred to remain nearsighted afterwards so they could still read without glasses. They were used to wearing glasses for driving and distance. On the other hand, the hyperope was happy with distance correction because now he or she could see something without glasses. These options worked well, but the drive for independence from glasses led to new strategies. Sticking with single vision lenses, there is an option called monovision. This diagram shows the concept of one eye at focus for a distance and one eye for near. Sounds a bit surprising, but it works pretty well. Typically, the dominant eye is set for distance and the other eye is set for near. This is common with contact lenses, and if people liked it, they could do the same with lens implants. Jumping ahead, there's another option, a hybrid with a monofocal lens for distance in the dominant eye and a multifocal lens in the non-dominant eye for close focus. Moving on to multifocal lenses. Early versions had two focal distances, but with a difference. One version had its foci set at far and near. The other version had far and intermediate. Each had a limitation, a missing distance, so it became an option to mix them using one lens of each type. The current generation of multifocal lenses aim to improve functionality at all three distances. The trifocal lens divides light into three different focal points, whereas an extended depth of focus lens, EDOF for short, aims to broaden the depth of focus. We will discuss both of these in detail a little further along. Last are the lenses that attempt flexibility. There are several design options, but this is the only one currently approved in the US. As we mentioned in the video on presbyopia, the focusing muscles in the ciliary body retain their ability to contract relatively late in life. The concept is that a flexible lens in the capsule could respond to muscle contraction by changing its position and thus its point of focus. The result? Measurements show some flexibility early on, but unfortunately by 1 to 2 years out, there's minimal movement, probably because the capsule has become scarred and stiff. With the single vision optic, this lens retains the advantages of good image quality and night vision. While lens implants are not perfect, the results are pretty good and continually improving. They have reached the point where lens replacement surgery is becoming an option for treatment of presbyopia. It is the same as with cataract surgery, except that you're not replacing a cloudy lens. Rather, the purpose of this surgery is to regain the ability to see up close without compromising distance vision. We finish our introduction by recognizing that multifocal lenses have compromises. First, because you're trying to focus multiple images simultaneously, there's an initial period of neuroadaptation in which the brain has to figure out how to deal with multiple images. Second, the image quality may be reduced, more so at near. Third, night vision is more likely to have issues with glare and halos and may be reduced in general. Part 4. We have talked about the lenses in general concepts. Now we will look at details of how they perform. On one hand, lens performance can be assessed technically by measuring vision at simulated different distances. On the other hand, we can look at patient experience, asking, for instance, how successful multifocals are at reducing the need for glasses. Also, how frequent are visual phenomena like glare, halos, and dark areas? And finally, what are common reasons for a blurred vision result? To measure how successful the lenses are at providing good focus at different distances, one tool is the, quote, defocus curve. Don't be intimidated by the name. I'll explain how this works. It will give you a good picture of how the lenses compare in function. This is a person, or eyeball, that has had lens implant surgery. We begin by measuring what distance prescription remains after surgery and correcting that amount, so we are starting at functionally zero correction. From there, lenses are added, usually in half diopter steps, which puts the eye out of focus. Vision is measured at each new power. Thus, in progressive levels of defocus. Here is what a defocus curve looks like for a single power lens. The x-axis is the amount of defocus, the y-axis is visual acuity. The vision with distance correction only is at the 20/20 level, the horizontal gold arrow. This is what we expect for an otherwise healthy eye. Since this lens implant is only aimed to be in focus for a distance, vision falls off as lenses are added, pushing the eye out of focus. With a minus or diverging lens, the focus is pushed behind the retina. The same effect as bringing an object closer to the eye, as happens with reading. A minus 2.5 diopter lens in front of the eye simulates a typical reading distance of 14 to 16 inches. Vision here is about 20/60, so reading glasses would be needed to see comfortably up close. Intermediate distance, like arm's length or computer distance, falls in between. So, the defocus curve gives you a nice picture of how the lens works at different distances. Now we look at a selection of lens types. The violet line is the crystal lens, the only flexible lens currently approved in the US. We discussed that over time it loses its ability to move and ends up performing like a single power lens. Regarding multifocal lenses, the added section of higher power for close focus results in the hill on the right showing better vision at reading distance. This low-add restore lens improves reading vision to between 20/30 and 20/40. The EDOF Symphony lens, the red line, does well at intermediate but falls off in reading. Both of these last two get by for light reading in good light, but reading glasses may be needed for longer reading or in low light. This shows the Restore Multifocal that comes in two different reading add powers. The higher add, darker line boosts near vision close to 20/20 without affecting intermediate. The last option is the Panoptix or trifocal lens, the green line. It aims to give focus at all three distances, measuring better than 20/25 at each. Much of the current lens discussion comes down to comparing the EDOF versus the trifocal. The trifocal has the advantage for reading, but is reported to give more glare and halos. Moving on to patient-reported vision results. Are multifocal lenses worth it? In order to compare the effectiveness of multifocal lenses versus monofocal lenses, the VA commissioned a study that reviewed recent literature in detail. Effectiveness is defined as the ability to reduce glasses wear. A similar study was undertaken by the Cochrane database. Since the results are essentially the same, we will just present the more recent VA study. The flexible lens had only one trial of limited quality. It did not make the VA comparison tables. These studies use a notation for vision that is different from the familiar Snellen notation, called log-mar. Without going into how it is generated, just note that 20/20 equals 0 on this scale, 0.3 equals 20/40, minus numbers are better than 20/20. Question number 1. How do multifocal lenses compare to monofocal lenses regarding distance vision? You don't want to make a significant compromise here. This analysis involved 15 studies of multiple lens types. It compares the difference in uncorrected distance vision between the two types of lenses. The diamond at the bottom is the average of all the study results. The vertical blue line is 0 difference. The result for distance vision is very close to that line, showing minimal difference between the lens types. Question 2 regards near vision, the whole point of going to a multifocal lens. The multifocals uniformly performed better at near, as expected. Taking this a step further, on a practical level, what is the chance of reduced use of glasses, ideally being free of glasses? Their answer is, compared to a person with single vision implants, a person with multifocal lenses has an almost 4 times chance of being glasses free. Let's look further. Another answer to this question comes from the lens manufacturer's own studies. Here they report what percentage of multifocal users were able to reduce glasses wear. This is PanOptix trifocal versus Symfony EDOF. Each asks the glasses question in a different way. For the PanOptix trifocal, the question was if they had worn glasses in the last 7 days. About 80% of patients reported not wearing glasses in that time, compared to those with monofocal lenses where reading glasses were needed over 90% of the time. For the Symfony EDOF lens, the question was how much they needed glasses. 85% reported the lowest category, they never wore or slightly needed glasses. Though interestingly, 60% of the monofocal subjects reported they never wore or slightly needed glasses. Nevertheless, the result is an impressive percentage for both. Previously, we talked about visual symptoms with multifocals compared to monofocals. Regarding glare, the VA study found a little more with multifocals. Regarding halos, they also found a little more with multifocals. Returning to the manufacturer's data for their results, with the trifocal lens, about half the patients noticed some level of symptoms, notably higher than in the single vision lenses. For the EDOF lenses, symptoms are less. Again, the monofocal controls show more symptoms in the trifocal study than in the EDOF study, which raises the question about comparability of methods, but at least it gives us a ballpark estimate. Last, contrast sensitivity is a measure of quality of vision. Monofocal lenses did better in 6 out of the 8 studies. Other series report similar results. For those who want to dig deeper, this is a recent technology assessment from the American Academy of Ophthalmology, which reports on the currently available lenses. Staying with this subject for another minute. Patient complaints after cataract surgery generally fall into 2 categories: blurred vision and distracting visual phenomenon. We have just covered glare and halos, so let's talk about blurred vision. First, refraction issues. After surgery, there can be some remaining amount of uncorrected refractive error. Calculation of lens implant power has gotten very good, but it's not perfect. One estimate is that 3/4 of surgeries end up within half diopter of their target. Pretty good. Then there is the issue of astigmatism. This has to do with the shape of the cornea being more oval-shaped like a football rather than spherical like a basketball. That can be reduced by astigmatism-correcting or toric lens implants, or by surgical measures like relaxing incisions at the edge of cornea during surgery, or a later refractive surgery like LASIK to fine-tune the correction. A substantial fraction of blurring relates to clouding of the lens capsule weeks to months after surgery. We need the capsule to hold the lens implant, but sometimes it has a downside. The orange layer on the back capsule here represents a layer of cells that have proliferated after surgery, causing clouding of vision. In this microscope photo, the arrow is pointing to clouding of the posterior capsule. Sometimes it looks like a layer of wax paper, sometimes it looks like a layer of bubble wrap behind the implant. The remedy for this is using a YAG laser to open the capsule. The arrows point to the edges of a nicely open capsule and vision is restored. To recap, distracting visual phenomena, glare, halos, and dark areas occur somewhat more often with multifocal lenses. Blurred vision can happen with either monofocal or multifocal lenses. It is important to add that there are non-lens-related causes of blurred vision. For example, macular edema, corneal edema, and others of varying severity. These would need to be identified and treated by your ophthalmologist. All modern lens implants contain a UV absorber to protect the retina. For comparison, the dashed line shows absorption for a middle-aged human lens. Whether to add a blue light absorber is a subject of current controversy. Some believe that adds additional protection for the health of the retina. Others believe it interferes with blue light input to circadian rhythms. A 2018 Cochrane review does not find evidence for either positive or negative effects. Part 5. With all that as background, we have now arrived at decision time. First, and most important, is it time for surgery? That decision point is different for each person. For cataract, is decreased vision interfering significantly with your daily activities like driving, reading, occupational, or hobby needs? For presbyopia, reading glasses are a nuisance, but what risk is it worth to be free of them? There are some new methods, specifically eye drops, covered in the presbyopia videos. It is important to realize that cataract surgery, like any surgery, carries risk of complications, including vision loss. They are uncommon, but a big deal if they happen to you, so think carefully about the risk versus the benefit. If you decide to proceed, then there is a lens to be chosen. You need to decide how much of a priority is freedom from glasses. Are there special occupational or hobby needs? Do you do regular night driving or other night vision activities? If you are accustomed to wearing glasses and don't mind continuing, single vision lenses in both eyes give a high-quality image, good low-light performance, and less vision disturbances. This is the less expensive option typically covered by insurance. If minimizing glasses wear is the priority, then multifocal lenses give good vision with an occasional assist from glasses. They are more likely to have visual phenomena that may be noticeable. These, quote, premium lenses come with additional cost, which is usually not covered by insurance. A monofocal setup is possible, but less common now. One more point. No matter what kind of lens implant you have, if you have a significant amount of astigmatism, then vision will be blurry without glasses. There are different ways to correct for astigmatism, including toric implants, as mentioned earlier. In the end, deciding if it's time for surgery and then choosing a lens requires a thoughtful discussion with your ophthalmologist. After successful cataract surgery, patients will sometimes comment, "Yes, I see better, but everything is so blue." Or, "It made me older. I see so many wrinkles." Or, "I can't believe my house is so dusty." Or, "Who chose my clothes? Nothing matches." As we come to the end of our discussion of lens implants, we should appreciate that it was only a few decades ago that cataract surgery was rudimentary, and there were no implants, only glasses with thick, heavy, vision-distorting lenses. Improvements in lens extraction methods and lens implant technology have made cataract surgery one of the most successful procedures in modern medicine. If you have not seen the accompanying video, it gives you the background for what we presented here. We reviewed the basics of cataract surgery, the first implant and early lens designs, then the major changes that led to the modern lenses as we saw in this video.